right, good morning. My name is Lisa Soltis. I'm a clinical nurse specialist at WakeMed Health and Hospitals in Raleigh, North Carolina. I focus primarily in critical care. I have 16 years in critical care nursing experience with that. And so today I'm going to discuss with you fluid optimization from a nursing perspective, and specifically look at particular case studies that we've run across in using different opportunities to try and maximize patients' fluid status with that. So again, I'm from WakeMed Health and Hospitals in Raleigh, North Carolina. We're a 1,000-bed health system, level 1 trauma center, neuro stroke center, heart center. So we do see a very wide variety of patients, as well as a heart failure accredited program as well. So we're going to start talking about some of the patients that we see. So today we've got a 74-year-old male who comes into the ED with shortness of breath. He's hypotensive, he's tachycardic, and he's brought to the ED by a family member. He hasn't been feeling well for the last several days. His past medical history, COPD, congestive heart failure, hypertension, renal insufficiency, GI bleeds, and he is an ex-smoker. Heart rate, as far as his vital signs, heart rate is 118, respiratories are 28, and very shallow. BP is 72/46, and his pulse ox is 85% on room air. So looking at that patient, very common. We see those types of patients walk in every day. So what would be our list of potential diagnoses in our differential? It could be a hypovolemic problem. He could be experiencing another problem with, as far as his history with GI bleeds. He could be short of breath because of an exacerbation of his congestive heart failure, and now that fluid's backing up into the lungs with that. COPD, he could be having an exacerbation with that and becoming hypoxic from that as well. And so when they walk in, to be able to just look at a patient and determine, is this hypovolemic, is it cardiogenic, and then also if he does have, possibly a pneumonia that's going on, it could also be a septic picture as well. So how do we diagnose and figure out what's going on? So typically the diagnostics we get, our labs, we'll get a 12-lead EKG, chest x-ray will help us rule out pneumonia, as well as identify pulmonary edema with that. The 12-lead will also determine if we have any ischemia or other cardiac problems that may be there as well. Echocardiogram will show us our left ventricular wall motion, contractility, our ejection fraction, the integrity of our valves, so we'll be able to determine how well the heart is pumping with that. And then we'll also screen him for SIRS and see, is this a potential septic patient with that. But looking at those things, that takes a while to get all of those tests put into place and all those other diagnostics. And so when you have somebody who's acutely hypotensive, pressures in the 70s, and you're trying to look at how do we change this patient, figure out what's going on, then what opportunities do we have? So there's new technology that is now available to us. It is based on bioreactants, which is a newer technology which actually looks at the phase shift change in the aorta and actually tells us what is the stroke volume, and so not completely 100% non-invasively, we're able to see what's going on with the patient within just a matter of a few minutes. We get a complete hemodynamic profile, and we can actually see, is this a hypovolemic picture? Do I need squeeze or cardiogenic problems, or is it a sepsis picture, or is there something else that's going on with this? The NICOM Reliant monitor then is the monitor that allows us to do that. It is the beauty of it. It is completely 100% non-invasive. So you have 4 electrodes. The nurses can place it at the bedside. That's one of the things that attracted me to this product, is that we don't need to have a physician or a mid-level or an advanced practice person to actually have to place an invasive line for us to be able to make a diagnosis and to actually clinically be able to decide how we want to treat our patients with that. The monitor itself then gives us our cardiac output, also gives us our cardiac index, which we all know is a better indicator of the overall cardiac function and how well their cardiovascular system is able to sustain perfusion through the body itself. It gives us our stroke volume index, also gives us our afterload as far as our total peripheral resistance and the peripheral resistance indexed as well, so that we can tailor it to that patient's body size and make sure that we've got the appropriate amount of squeeze as far as the vascular tone with that. The other interesting components is, as the monitor continues to evolve, we now have the ability to measure oxygen delivery, so we can program in their hemoglobin, oxygen saturation, and so we can also again maximize oxygen delivery to the tissues as well. So looking at the numbers, cardiac output, cardiac index, cardiac output is just our heart rate times our stroke volume. When you index it, you take the output, divide it by the patient's BSA, and then it customizes that output for that patient's body size, body habitus, lets us know, is this adequate for that particular patient? The total peripheral resistance then is my afterload. What is my vascular tone? And so again, do I need to, either vasodilate because they're clamped down, or do I need to, add fluid and then constrict to try and increase vascular tone with that? The stroke volume index then, stroke volume is, the amount of volume that's ejected from the heart with each beat, each systole. And then stroke volume index is, again, we take that stroke volume and then we index it to that patient's body size. And again, a better indicator of not just the raw number of volume that's being ejected with each systolic beat, but it also tells us then, is it sustainable and is it enough for that particular patient? So we're going to go over some different case studies, and we have different hemodynamic profiles, and they're all distinct that we would see with patients with these different problems as far as perfusion with that. In a cardiogenic picture, we typically, obviously, it's a problem with the pump. So I've got good vessels. Patients will have normal volume or adequate volume, and it may be elevated volumes with that. But then we'll also see then a very low cardiac output with that. So my preload is typically high. My afterload, what we're pumping against, is typically high because the body's going to induce that stress response. It's going to vasoconstrict to help augment perfusion, but then it causes the cardiogenic picture to be exacerbated with that. The key with this patient is that when we try and assess for fluid responsiveness, whether if we give a bolus or we do a passive leg raise, they will not be fluid responsive, and that will be a distinctive marker for us to know this is a cardiogenic problem. This is not a volume problem. When we look at our septic patients, again, a very distinct hemodynamic profile. Typically in early sepsis, we'll see a very large cardiac output and index. The heart is trying to compensate for the decreased perfusion. Afterload, they're going to be profoundly vasodilated. So the TPRI is going to be very, very low, which is another classic picture. And typically their volume is low because, again, the amount of vasodilatation that is there doesn't support oxygenation, doesn't support perfusion. And so, again, volume resuscitation is critical for sepsis. We all know that this is, on the horizon, and the increased awareness of the volume resuscitation and the antibiotics. And so, again, within a matter of minutes, I can determine my patient's septic, and I can adequately fluid resuscitate without having to put an invasive line to guide my fluid resuscitation for that patient. Hypovolemic patients, we'll see a low cardiac output and we'll see a high afterload, and in this case then we have very low volume with this. When we do a passive leg raise or a fluid challenge with these patients, again, we will now see they are fluid responsive, so that I've got a good pump, I've got good vessels, I just don't have enough volume in the tank, and so we need to again resuscitate that patient until we have adequate volumes with that. So we discussed how we would be able to differentiate between cardiogenic, hypovolemic, and septic shock. And so cardiogenic, we know that they're not going to be fluid responsive, and we'll actually see their cardiac function decrease when we do a passive leg raise because the heart is the problem. The pump is the problem. It can't handle that extra volume. Hypovolemic, low cardiac output, high afterload, high TPRI, and then we will see that they are fluid responsive when we do our passive leg raise. And distributive shock, early, very high cardiac output and index, very low afterload, very low TPRI, very low volumes because of the amount of vasodilatation, and again, profoundly fluid responsive with this. The other caveat to sepsis is that the heart can't sustain a cardiac output of 8 to 10 liters for very long. So eventually their cardiac function is going to, kind of diminish over time because their heart can't keep that up. So assessing fluid responsiveness, again, we go back to, in healthcare, everything kind of that goes around comes back around again. And so a very simple technique that we've been utilizing for years and years and years is now, coming back into the forefront as far as how we care for our patients, because it's a very simple test that we can do. And now with our non-invasive technology, we have the ability to assess their responsiveness and assess, do they need that volume. So a passive leg raise, when we lay our patient down and raise their legs, that gives about a 200 to 300 ml fluid bolus with an increase in venous return back to the heart. Then this technology, the NICOM, then is able to measure what does the heart do with that extra volume, and then that can help us predict how fluid responsive they are. The monitor itself then looks at the baseline data, Then it looks at what was the change when we raised their legs, and by doing that, then we can determine, based on the numbers that we get, whether or not they're fluid responsive. If we see those numbers go down, then we know they're not fluid responsive, and they may actually be fluid overloaded. So again, we have to look at the whole clinical picture with that. So how does assessing fluid responsiveness help? Well, we all know that, having adequate volume in any critically ill state is going to be the mainstay of our treatment. And so now we have a way to be able to measure that and make sure that we have adequately resuscitated, especially if we have somebody who's profoundly hypotensive and we need to add squeeze, we need to add those vasopressors. And if we don't have adequate volume before you add a vasopressor, what you're going to end up seeing is that you'll create a metabolic acidosis, because we're squeezing out in the periphery, and if our cardiovascular system is empty, I'm squeezing empty vessels, and that will create an anaerobic metabolism, lactic acid production, and a metabolic acidosis. So extremely important that we fill the tank before we add the squeeze to the vessels. Also allows us to assess then if I need to enhance contractility. Also will let me know if I need to, again, enhance vascular tone, or if they're fluid overloaded, and do we need to now consider, do we need to pull some of that volume off because their cardiac function can't handle that extra volume. So a couple of case studies, and these are real case studies that I was personally involved with when we first started looking at this monitor, and we saw tremendous outcomes with this. So this was a step-down patient, post-open carotid endarterectomy. They were on a cardiac step-down floor. The patient, they called a rapid response. The patient's blood pressure was dropping. They were on a low-dose dopamine drip, and the nurses then, instinctively thought, well, his pressure's dropping, so let's increase the dopamine, let's increase his vascular tone, and bring his blood pressure up. Of course, he didn't respond to that because we're just adding squeeze, but there's no volume in the cardiovascular system. But prior to that, we didn't have a way to be able to detect that. So then we put the NICOM on, and it showed the patient was fluid responsive. As we put that the NICOM on, then we saw that when we did our passive leg raise, the patient needed volume. We actually gave a 500 ml bolus. We backed off on the dopamine. His cardiac function improved, and his blood pressure and MAP came up based on the volume that we gave from that. So again, we were able to manage the patient in the step-down unit, avoiding the transfer and the bounce back to the ICU, and that's a significant savings or avoidance of cost of at least $2,000 to be able to successfully manage that patient, and it helps, again, facilitate patient flow and help keep things moving, running smoothly on the floor itself. A second case was a patient who has a long-standing chronic history of rapid AFib. He had an acute exacerbation that brought him into the hospital, and with that, he was rapid heart rate, went into a profound congestive heart failure, fluid overload. The patient continued to deteriorate, and we ended up placing him into the critical care intensive care unit to help manage his fluids as well as oxygenation. His respiratory status continued to decline, so then at that point we ended up having to intubate him and put him on a ventilator with that, and then we continued with aggressive diuresis. The Lasix, then we were giving him Lasix BID, so twice a day we were diuresing him, trying to pull that fluid off. And so after about 2 days of the continuous Lasix, then he started to no longer respond to the Lasix. And so they were now, his BUN and creatinine were starting to rise. There was concern about renal insufficiency and renal failure at this point. So I was called to come see the patient, and I asked, well, let's put the NICOM on and let's see what was going on here. And what we saw was very distinctive, that it was a cardiogenic picture. So he was, his cardiac index was about 1.7, 1.8. It was very low. He was not fluid responsive. During the night, prior to putting the NICOM on, they had DC'd all the Lasix for about 12 hours. About 6 a.m., his pressure continued to drop. The nurse called the doctor and said, his pressure's dropping, and they said, well, maybe we dried him out too much, so give him a 500 ml bolus. So they gave him fluids, and then when I got there, around 7 or 8, to come see the patient, then we put the NICOM on. When we did our passive leg raise, he was profoundly fluid unresponsive, and his cardiac function actually decreased by more than 26%, which meant he was profoundly fluid overloaded. So so here we were thinking we dried him out, we wanted to volume resuscitate, and that was not the problem, and we were able to determine, again, within a matter of minutes, this was a cardiogenic picture. We added dobutamine to his treatment plan. We saw his cardiac function improve, again, within a matter of minutes. Within about 30 minutes, we saw urine starting to come back out again, and he started producing urine again. His renal function improved, and we actually were able to cancel the order to start continuous renal replacement therapy. So again, the expense with that can be anywhere from $5,000 to $8,000 a day, and we avoided that because we were able to enhance contractility. He started responding to Lasix again and started diuresing profoundly, which again was the beauty that we were able to definitively figure out what was going on with him and whether or not we needed to continue to. So again, when we looked at his fluid responsiveness, a decrease in cardiac function of 26%, which meant the heart could not handle that little 200 ml bolus from that. So again, adding that inotropic therapy, we were able to avoid CRRT, and again, a tremendous savings with that. So, the other question that I always get is, well, how accurate it is, because it's, people are very skeptical. It's completely non-invasive. When you say non-invasive, people are thinking of bioimpedance, which wasn't very accurate and, didn't really gain a lot of credibility because there were a lot of challenges with that. And so again, this is bioreactance, a completely different technology. So I work in an open heart unit, so all of our patients typically will come out with a PA catheter. So we were able to put the NICOM on these patients with a PA catheter to be able to see, okay, is it really accurate, and I know the validation studies say that it is, but I'd like to see it with my own eyes. So we looked at a patient, we measured their PA numbers, every few, minutes as far as the intervals and the NICOM numbers, and they were spot on. I mean, they were right on top of each other. Now, the other interesting thing was one of the patients that we had in particular, output and index started to drop, their stroke volume dropped a little bit, and so the doctor gave us an order to give a fluid bolus. We gave the bolus. On the NICOM, because you have instant beat-to-beat data, we saw the output and index increase, we saw the stroke volume increase, immediately as we gave that fluid. PA catheters take the data and they average it over, depending on how it's set, from 60 to 180 seconds. So it can be several minutes. And so we did see the PA catheter measure, or mimic that same trend, but it took it about 3 minutes to actually catch up. But when we saw almost immediately when we had them on the NICOM itself. So again, when we saw that fluid bolus, we saw them improve significantly. Another typical case, 94-year-old woman who came into the emergency department, chief complaint, dizziness, tachycardia, not feeling very well, very low blood pressure. She had, very dark stool. She did have a history of GI bleeds with that, but neurologically she was intact. And for a 94-year-old, she was very spry, very much with it. Past medical history, congestive heart failure, GI bleeds, anemia, chronic AFib. Her ejection fraction was preserved at 55%, so she did have good cardiac function with that, and she also had aortic stenosis. So our plan, assess her oxygenation, rule out the GI bleed, and try and figure out why she's so hypotensive. When you have a patient with a history of congestive heart failure, then most of the time we're very leery about giving fluid, right? Because we don't want to fluid overload them. We don't know how well they can handle that. So our typical bolus is anywhere from about, maybe 250 to 500 mLs for that. So for this patient, we did a passive leg raise just to see, is she fluid responsive? Is this a fluid problem that we need to do? And so when we did that, when we actually did the passive leg raise with her, we saw a 38% increase of fluid responsiveness. So that meant she was tremendously. Typically when we see the SVI increase by more than 10%, what we'll typically see then is that they are fluid responsive, and the fact that hers changed to 38% was tremendous. So we knew she was fluid responsive. We then, to mimic it, to see is this really, does the PLR actually work? Then we gave a 250 bolus. We gave it over a period of about 1 to 2 minutes to make sure that the patient really was fluid responsive, and we saw the exact same trend as far as that she did need that volume. So we adequately fluid resuscitated her in the ED. We were able to manage her there in the ED, correcting her hypotension as well, and then we transferred her to step down rather than sending her to ICU because she, when she first came in, we were thinking she would need critical care. So again, cost avoidance of upwards of $1,400 a day or more because she did not need that ICU care. Another case, we had, again, an ED admission, 68-year-old male who his chief complaint was confusion and very lethargic. He lived in a group home. The people that were there said, he wasn't quite acting right, wasn't quite himself, so they brought him into the ED to be assessed for that. Past medical history of diabetes, hypertension, stroke, end-stage renal disease, and also he had hepatic and liver disease as well. His vital signs, 98.4, heart rate was 103, Raspers were 44, his BP is 90/47, so he was hypotensive and his MAP was very low for that. His chest x-ray was clear, his EKG was normal, so this was not a cardiac problem. When we checked a lactate level, it was 15.3. Now for lactates, typically greater than 2 milliequivalents or millimoles is abnormal. When it gets greater than 4, then that meets the criteria for sepsis. And he had a lactate of 15.3 when he walked in. Now he had a renal history, so I have my intensivist, I have the ED physician, and I have the nephrologist there. And we put the NICOM on to see where he was. Again, tremendously fluid responsive. His cardiac output was 8.8, his cardiac index was 5.4, so his heart is pumping like a horse in there. His afterload, his TPRI was in the 400 to 500 range. It would vary between 4 and about 700. His stroke volume index was only 15, and normal, we're looking at least 35 to 45 is what we're trying to see with a stroke volume index with that. His passive leg raise, he was 45% fluid responsive, so again, showing he was tremendously, hypovolemic, and he needed a very aggressive fluid resuscitation. His MAP still remained in the 40s. Now, having a conversation with a nephrologist who wants to give a 250 bolus to try and volume resuscitate, and we collaborated as a group, and again, we had a multidisciplinary group there, and we all really agreed that this patient needs volume and he needs a lot of it, and so we decided we were going to aggressively fluid resuscitate and see if we could make a difference. So what we did, continuing our assessment, white count was greater than 30,000. We placed a Foley, and he just had awful foul, green, foul-smelling urine, so we definitely had a UTI there. We were able to use the NICOM to assess his fluid responsiveness and assess when have we adequately fluid resuscitated with that. So we gave a total of 3 liters of fluid in about 2.5 hours. So that was, other than the antibiotics, that was our main focus, was the volume resuscitation. So 3 liters in about 2.5 hours with that. What we saw then when we rechecked a lactate, his lactate had been 15.3 and it came down to 8.4. So again, more than a 50% decrease in his lactate just on volume alone. Then at that point he was no longer fluid responsive, his stroke volume index was normalized, and then we were able to add the levofed and add the squeeze. We filled the tank, now it's okay to squeeze, and that's going to support perfusion with that. We also looked at his SOFA scores. So the SOFA scores are the Sepsis Organ Failure Assessment scores, and it's been well researched and documented that when you assess your organ failure when they come in with sepsis, and if that number doesn't improve within 48 hours, then mortality rates are very high, survival rates are not very good, so it's not a good prognosis with that. When he came in, his SOFA scores then were 13. When he first came in, and just after 24 hours his SOFA score dropped down to 8, so that was a tremendous improvement, indicating again his survival rate was very good. Bottom line, when he came in, he was supposed to be on a medical non-telemetry floor. We were able to recognize that he was in severe sepsis and that he already had organ involvement with that. We sent him to the ICU. He was never intubated. He was in the ICU for 2 days, and he went back home, actually back to the group home in 6 days, which was a tremendous success because he never got into the full-blown severe septic shock, and we were able to resuscitate him and turn him around quickly. Another interesting case we had was a hemodialysis patient. She's 27 years old, had multiple comorbidities, so she was not in the greatest state of health to start with, and she came into the emergency department extremely fluid overloaded. So again, they ordered dialysis for her. Now the challenge with dialysis is it's a lot of guesswork. We go on their weight, their dry weight, we guess at how much to take off, and if we take off too much, then they crash because they're hypovolemic. If we don't get enough off, then they crash because they're still fluid overloaded and they go into pulmonary edema. So we put the NICOM on just to see where she was, and they had already started the dialysis treatment. When we put her the NICOM on and we did a passive leg raise, the orders were to pull off 3 liters in her treatment. They had pulled off 2.5 liters at that point, and she was already extremely fluid responsive, indicating that we had already pulled off too much with that. The dialysis nurses recognized that. They actually gave back 500 mLs of volume to the patient. She was no longer fluid responsive. Then they ended the dialysis treatment, and we did see a tremendous improvement in her oxygenation with that. When we looked at her admission x-ray, it's almost completely whited out with the amount of pulmonary edema that was present, and within a matter of a few hours later after her dialysis treatment, her lung function and x-ray looked tremendously improved with that. So outcomes, it's all about outcomes, and the beauty of this device is that it empowers the nurses to be able to place it at the bedside, completely non-invasive. It's completely painless for the patients. We don't need a consent or a doctor's order to do this, and within a matter of moments we can get a hemodynamic profile to help us then determine what's our plan of care and what's the underlying pathophys for our patients, and what do we need to do as far as treating that. We have seen since then just numerous cases where we've been able to turn things around, where we've been able to look at a patient when they come in and think it's one thing, and then we realize it's actually something else, and so we were able to change our plan of care appropriately and actually turn our patients around with that. So when to think about using this type of technology, when you have somebody that's in pulmonary edema and you're trying to determine is this cardiogenic or is it some other pathological process that's causing them to become fluid overloaded. When they're hypotensive, and again within minutes I can determine is this cardiogenic, is it a vascular problem as far as vasodilated and a sepsis picture, is it a hypovolemic problem? So again, I can very quickly assess and determine what's going on with the patients, or whether or not they need to add inotropic support and squeeze to